Myocardial stunning is reversible myocardial dysfunction after ischemia and reperfusion. It is different from myocardial hibernation, in which persistent chronic ischemia causes myocardial dysfunction, which is reversible after revascularization. Mechanism of myocardial stunning is thought to be either due to oxygen-free radicals or calcium overload produced by the ischemia-reperfusion sequence. Myocardial stunning is the reason for persistent left ventricular dysfunction for hours or even up to a few days after successful reperfusion in acute myocardial infarction. This can be noted after reperfusion by thrombolysis or percutaneous coronary intervention. Repetitive episodes of stunning secondary to ischemia can lead on to hibernation. Lower myocardial necrosis, as suggested by a lower peak creatinine kinase level, has been shown to be an independent predictor of recovery of ventricular function. Though almost half of the recovery of left ventricular function occurs later, the ejection fraction achieved on third day after myocardial infarction is predictive of survival. Hibernating myocardium is a chronically ischemic myocardium, the function of which improves after successful revascularization. Short of revascularization, presence of hibernating myocardium can be documented by improvement in regional or global function of the left ventricle in response to nitrates, inotropes, and post-extrasystolic potentiation. Nitrates delivered sublingually or as an infusion during a wall motion study, either by echocardiography or by nuclear perfusion imaging, can document improvement in wall motion due to improvement in the circulation. Inotropic stimulation during echocardiography can also document similar improvement in wall motion during low-dose stimulation. Post-extrasystolic potentiation is a simpler method as it does not involve any additional measures, only just longer period of imaging. The beat after a ventricular premature beat has natural augmentation of inotropic state of the myocardium due to increased availability of intracellular calcium. The ectopic beat, though it releases calcium, does not utilize it fully. Hence, part of it is available during the post-extrasystolic beat in addition to the regular amount of calcium being released during the index beat. The extra calcium invokes an inotropic response in the hibernating myocardium, which manifests as an improvement in wall motion during echocardiography or perfusion imaging. Myocardial hibernation can be considered as an adaptive response of the myocardium to chronic ischemia to improve survival of the myocytes. As the chronic ischemia progresses, there seems to be a perfusion contraction mismatch which occurs to preserve viability. A non-contracting myocardium needs only less amount of aerobic metabolism to maintain viability. Dobutamine stress echocardiography, myocardial contrast echocardiography, single photon emission computed tomography, and positron emission tomography are the important modalities of assessing myocardial viability and thereby establishing the possibility of hibernating myocardium in the setting of chronic ischemia. You may wish to check out another video on this channel on assessment of myocardial viability. Myocardial contractility recovers significantly in hibernating myocardium after successful revascularization, but the period needed for recovery varies depending on the duration and severity of ischemia which induced the hibernation. In chronic severe hypoperfusion, it may take several weeks for the completion of recovery process. This is because the amount of contractile proteins may have decreased due to the catabolic wasting which occurred during the chronic ischemia. New protein synthesis after successful revascularization takes a longer period. Myocardial viability assessment is important prior to decision on revascularization. The term viable myocardium is applied to myocardium with a potentially reversible contractile dysfunction in patients with coronary artery disease. It can be divided into stunned myocardium and hibernating myocardium. Stunned myocardium has prolonged contractile dysfunction after a transient ischemic episode and coronary reperfusion. This automatically recovers over a period of time. Stunned myocardium is commonly noted after thrombolysis and primary percutaneous coronary intervention. Hibernating myocardium has reduced contractile function due to persistently impaired coronary blood flow. Hibernating myocardium regains contractile function partially or completely after revascularization. The goal of myocardial viability assessment is to identify those patients who will improve with coronary revascularization. It is useful to triage those with heart failure into ones which require revascularization versus those who require left ventricular assist devices or cardiac transplantation. It can predict the recovery of myocardial function with treatment and thus the prognosis. Assessment of myocardial contractile reserve can be done by echocardiography and other imaging modalities. Segmental thickening and systolic function can be assessed by echo and MRI. Myocardial perfusion can be assessed by single photon emission computed tomography and myocardial contrast echocardiography. Metabolism of myocardial cells are assessed by positron emission tomography. Myocardial scar can be detected by CMR, seen as late gadolinium enhancement or LGE, and by multi-detector computed tomography. Myocardial viability assessment by echocardiography. Diastolic wall thickness will give an idea regarding the myocardial viability. Thin and hyperdense myocardium is likely to be scarred and non-viable. Dobutamine stress echocardiography documents the contractile reserve of the myocardium and hence indicates viability. Myocardial perfusion is assessed by myocardial contrast echocardiography. Strain and strain rate imaging is done by tissue Doppler and speckle tracking. There are various methods of assessing diastolic function using Doppler and tissue Doppler echocardiography. End diastolic wall thickness is one of the simplest methods to screen for myocardial viability, which cardiac surgeons check most often. End diastolic wall thickness more than 5.5 mm has a sensitivity of 94%, albeit with a low specificity of 48% for detection of myocardial viability. With end diastolic wall thickness less than 5 to 6 mm, less than 5% will be viable, while with thickness above that, viability is more than 50%. Pharmacological stress echocardiography can be done using dobutamine, adenosine or dipyridamole. Low-dose dobutamine echocardiography is useful in assessing myocardial contractile reserve. Parasternal and apical windows can be used to assess the response in 16 to 17 myocardial segments. Higher doses of dobutamine can be used to check whether there is any biphasic response indicating ischemic viable myocardium. The response to dobutamine can be divided into 4 types. In monophasic or sustained response, low-dose dobutamine increases the contraction, which is further enhanced in high dose. In biphasic response, low dose enhances contraction while high doses decrease the contraction. Another type is ischemic response, in which both low dose and high dose produces decrease in contraction. In non-phasic response, there is hardly any contraction of the segment throughout. Roughly 40% will have a non-phasic response, while nearly one-third can have a biphasic response. Sustained response may be noted in nearly 1/5 and worsening may be noted in 15%. Biphasic response had the highest predictive value for recovery of function after coronary angioplasty. Non-phasic and monophasic responses predicted poor recovery of function, while ischemic response was in between. Dobutamine stress echocardiography has been noted to have better specificity than nuclear imaging. DSC has a fair value in prognostication as well. Echo-based techniques for assessment of myocardial viability has certain advantages as well as limitations. Echocardiographic techniques are safe and do not have the risk of ionizing radiation like nuclear perfusion studies and positron emission tomography. Due to portability of echocardiographic equipment, Even bedside evaluation is possible and the equipment are widely available. Cost of procedure is much less compared to nuclear imaging studies. Unlike cardiac magnetic resonance imaging, presence of pacemakers and defibrillators are not a problem. Other coexisting cardiac pathology can also be assessed by echocardiography, and there is a good relation between echocardiographic findings and outcome of revascularization. Both image acquisition and interpretation of images are operator dependent, and there could be significant inter-operator variability. Spatial resolution of echocardiography is relatively low compared to other techniques. Poor echo window, like those in patients with chronic obstructive pulmonary disease, can affect the diagnostic accuracy significantly. There is a tendency to underestimate viability, leading to a lower sensitivity for echo-based techniques. Myocardial contrast echocardiography has been used in the assessment of myocardial viability. Downside of myocardial contrast echocardiography is the cost of ultrasound contrast agent. Intravenous administration of contrast improves the visualization of myocardial segments and enables the assessment of perfusion. Myocardial segments with normal perfusion and those with patchy perfusion are considered to be viable. Those segments which have no perfusion are taken as non-viable myocardial segments. Ultrasonic contrast agent consists of ultrasonic microbubbles. A study compared myocardial contrast echo with gated single photon emission computed tomography for detection of significant coronary artery disease. The study had enrolled 628 patients with more than one cardiovascular risk factors in 99%. 516 patients underwent myocardial contrast echocardiography, technician 99M labeled ECG gated SPECT, and quantitative coronary angiography. About one-third had coronary stenosis of 70% or more. 131 had single vessel disease and 30 had multi-vessel disease. 310 had coronary stenosis of 50% or more. They documented higher sensitivity for myocardial contrast echocardiography than SPECT, though with lower specificity. An accompanying editorial was slightly skeptical about the role of myocardial contrast echocardiography. They mentioned that the study missed one of its primary endpoints in the form of non-inferiority of specificity for detection of 70% or more coronary stenosis. Myocardial strain is a measure of deformation of a myocardial segment relative to its length. Strain rate is the rate at which the deformation occurs. This is in effect the gradient between velocities at 2 points. Strain and strain rate can be measured echocardiographically using tissue Doppler and two-dimensional speckle tracking. A change of radial myocardial strain of more than 9.5% has been shown to have a sensitivity of 83.9% and a specificity of 81.4% for detection of myocardial viability. Change in longitudinal myocardial strain more than 14.6% had a sensitivity of 86.7% and specificity of 90.2% for detection of myocardial viability. Low-dose dobutamine infusion at 10 microgram per kg per minute along with strain rate assessment is useful to assess myocardial viability. Increase in peak systolic strain rate of more than minus 0.23 per second gave a sensitivity of 83% and specificity of 84% compared with FDG PET as gold standard for detection of myocardial viability. Thus, increase in peak systolic strain rate during low-dose dobutamine infusion permits discrimination between viable and non-viable myocardial segments. Cardiac magnetic resonance imaging can be used to assess myocardial viability. Preserved myocardial wall thickness of more than 5.5 mm has a good sensitivity of 95% but low specificity for detecting myocardial viability on CMR. Delayed or late gadolinium enhancement on CMR indicates myocardial scar. If the extent of scar is less, as indicated by less than 50% transmural extent of hyperenhancement, it indicates viability. If 4 or more dysfunctional segments show viability, it has a good sensitivity of 95%, again with low specificity of 45%. Dobutamine cine MRI is useful in assessing the contractile reserve of the myocardium. Improvement in myocardial thickening of more than 2 mm with low dose dobutamine CMR is indicative of viability. CMR has the advantage of an accurate assessment of the extent of myocardial scar with superior spatial resolution. Wall thickness can be accurately measured by CMR. The image quality is not limited by characteristics of patient chest wall as in echocardiography. There is good inter-observer and intra-observer agreement in the assessment of LGE. CMR has good sensitivity and a fair specificity. Some of the limitations of CMR are its high cost, limited availability, longer imaging time, and restrictions in patients with cardiac implantable electronic devices. Claustrophobia of patients may sometimes prevent CMR imaging. Gadolinium enhancement is not suitable in those with low glomerular filtration rate of below 30 ml per minute. Irregular heart rhythms make gating difficult. Sick patients may find breath holding difficult. While performing dobutamine stress, there are technical difficulties in monitoring the patient in the MRI suite. Multi-slice computed tomography can be used for assessing myocardial viability. Iodinated contrast used for CT scanning accumulate in infarcted myocardium, similar to what happens with late gadolinium enhanced MRI. With the high spatial resolution inherent to MDCT, differentiation of transmural and subendocardial infarction is possible. Old infarcts have lower density on CT compared to recent infarcts. In general, there is good agreement between LGE MRI and late enhancement noted on MDCT. In a comparison with dobutamine stress echocardiography, MDCT with 64 slice CT, findings agreed with stress echo findings in 97.3% of the myocardial segments analyzed. Disagreement was noted only in 2.7% of the segments. Overall, MDCT has not become as popular as echo, CMR, technetium 99M systemib and PET for the assessment of myocardial viability. MDCT has higher radiation exposure than other modalities, and it does have a potential risk of contrast-induced acute kidney injury. Rust and nitroglycerin myocardial viability scan. Rust images were obtained after intravenous administration of 8 millicurie of 99M technetium. 25 millicurie of 99M technetium was injected hours later and after 0.5 milligram of sublingual nitroglycerin and rust-gated images obtained. Exercise was deferred in view of clinical background of triple vessel disease and severe left ventricular dysfunction. Rust images showed a moderately dilated left ventricle and no pulmonary uptake of tracer. Perfusion abnormality was noted in the inferior wall and infralateral segments. There was some improvement of perfusion with nitroglycerin. Gated single photon emission computed tomography analysis showed global hypokinesia with a global ejection fraction of about 23%. Positron emission tomography is usually taken as the gold standard for assessment of myocardial viability. PET scan with 13 ammonia gives the perfusion, while 18 FDG shows the metabolic activity of the myocardium. A mismatch between perfusion and metabolism, whereby underperfused region of myocardium is shown to have active metabolism, is an indicator of myocardial viability. Important advantages of PET are that validity is well established and it has an excellent sensitivity. PET can be done in patients with cardiac implantable electronic devices, while CMR is not suitable in that situation. Compared to single photon emission computed tomography, PET has a better spatial and temporal resolution with better quality of pictures and less radiation risk. The most important limitation of PET is its high cost and limited availability. It has some radiation risk when compared to echocardiography and cardiac magnetic resonance imaging. Here are the first set of references on myocardial viability assessment. Second set of references are here. These are the third set of references.